Okay, dear colleagues, dear friends, with the most important man having come in now, we'll start the session. Sharok will definitely arrive a little bit later, because he always arrives a little bit later. It's of course an academic entrance, so I will stop if he comes in, we'll applaud for him, etc. Hopefully make him feel a little bit embarrassed. We won't. One thing I'm telling you now, and we'll tell you that again after the meeting, the people of Nucleus have a sort of test kit outside when you leave the room with 5 EpiCheck tests that you can use at home, and please give them some feedback how you think it works from a practical point of view, etc., etc. So at the end of the session outside you will have a box or whatever. What is it? Oh, you get a registration to receive. Okay, sorry, you don't get the physical stuff, but you can register to have 5 test kits in your hospital to try to use for your patients. The session is called Breaking the Glass Ceiling of Urinary Markers and Muscle-Invasive Bladder Cancer Monitoring. So my background is I'm a urologist. I started urology in '92. That's when I finished my training. I chose for bladder cancer. I don't know why, but I chose for bladder cancer. And the first decade of my being a urologist, I did a lot of work on markers. We tested them all the FDA tests, NMB22, BTA, whatever. We tested them all. And they never really fulfilled my needs within the clinical use. And I still think currently most of the markers that are available, have been available, some are even FDA approved, don't really fulfill the markers of us urologists nor of our patients. I really checked the last. I asked my patients, so what do you want? What kind of test do you want? And the tests that we have had available for a long time didn't fulfill those needs. So that's actually my old frustration. Bladder cancer is something, of course, which is very prominent, and it's not only the incidence rate, the number of new patients, but specifically because we see a lot of recurrences in non-muscle invasive bladder cancer, on average 50%. Those patients just keep coming back, and that means that we do a lot of studies, a lot of cystoscopies in those patients. 2.7 million patients are being followed up currently. They get 3, 4, 5 cystoscopies a year, so you can see that it is a very important topic and a significant problem for healthcare, for patients, for us urologists, the workload, and obviously also for healthcare budgets. With regard to the last, we checked it with a nice group, economics group in London. They know nothing about bladder cancer. I know nothing about economics. My wife does, I don't. And they checked for me, so what do we spend in the European Union on bladder cancer? And I was really surprised to see what we spent on bladder cancer. That's 5% of total healthcare costs are spent on bladder cancer. And that differs a lot per country. Bulgaria, apparently, as you can see, is relatively cheap. France is relatively expensive. So there are a lot of differences per country, but still, it's a very expensive disease. And that in part is not only come because what we do as a doctor to our patients, but also productivity loss. Patients come to our department, they can't work that day or maybe even the day after. Informal care, because they had an infection, they have to ask the neighbor to do the shopping, to go to the grocery store. So there are a lot of costs that are accompanied with bladder cancer care, bladder cancer follow-up. So it is a very expensive disease. And a lot of those costs are in follow-up of non-muscle invasive bladder cancer, as you probably know, because hopefully and probably that is a substantial part of your outpatient work. So this is the bladder cancer costs. We have a speaker from Austria, not here yet. We have a speaker from Italy. He's here. We have a speaker from the UK. He's here. And we have a speaker from the Netherlands. That's me. And you see that we are relatively expensive countries. France is most expensive. That's why we didn't invite a guy from France. But it's a costly disease. You can see that here. Unfortunately, that doesn't translate into funding of research. These are, of course, a little bit older data, but I don't think they really have changed a lot. And that's of the National Cancer Institute cancer research funding in the US. And you see here the big 4, lung cancer, prostate cancer, breast cancer, and colorectal cancer, the big 4. There is hundreds of millions of dollars spent on research every year for these tumors. And then if you look at bladder cancer, it's a very simple $20+ million per year. So that's less than 10% of, for example, prostate cancer, whereas it is more prevalent than prostate cancer. And if you look at my department, and of course we do a lot of cancer in general, but also a lot of bladder cancer, we spend more money in my department on bladder cancer, and we earn more money than every other tumor in my department of bladder cancer. So also in my department, it is the, let's say, most costly disease. So we are going to do a workshop. I will do the introduction. I've almost done that. I will then discuss with you the multi-center European study that we've done. After that, I don't think this is the old schedule. Jim, I think you're third or not?
No, that's the correct schedule.
This is the old schedule, eh? This is the new schedule. Great, then you change that, even better. So then Jim will be second after me with some case studies and clinical implementation of the test in monitoring non-muscle invasive bladder cancer. Sharok from Vienna, Sharok Shariat, will then discuss how in his view, a bladder cancer test has changed decision-making for patients with non-muscle invasive bladder cancer. And Roberto Maioni from Italy will then discuss the research beyond non-muscle invasive bladder cancer. What can we expect in the near future in general and with this test? And I will then conclude this session. What about the scene? Biomarker issues. If you look at the European guideline, because there are some issues in bladder cancer, sensitivity of the markers that we have available is usually higher than cytology, but at the cost of a lower specificity compared to urinary cytology. Benign conditions, previous BCG, the TOR will influence many of those urinary markers, then you will have a lot of false positives. The requirement of a sensitivity and the specificity of a urinary marker largely depends on the clinical context. For screening, primary detection, follow-up of those different categories, you have different demands for the tests with regard to sensitivity and specificity. There is a very wide range in the performance and low reproducibility in the tests that we currently have. I will show that in the next slide, and that is probably due to patient selection, complicated laboratory methods, etc., etc. And then there are those nasty patients with a false positive test, which then maybe identifies a future recurrence or progression, but that's of course something that is difficult to predict. The consequence is that currently, even in the 2018 guideline of the EAU, urinary markers are not recommended for clinical practice. Just by show of hands, who of you is using a urinary marker in clinical practice outside a research question? Okay, so that's an unmet need. Nobody showed up his hand. Or one maybe there? Or you were taking off your coat? No, okay, doesn't count. And here you see the table in the guideline, and you see that the sensitivity, the specificity, the performance varies enormously. So that basically is not something that is really reproducible and usable. And my thoughts are, apart from the table, cost issues. Will differ per country, will differ per continent. Are we going to use a point of care test, or is it a test that requires some lab investigation? Because depending on the population that you're going to look at, you want a rapid result. If you want to do the test and follow up, of course, you don't want to wait awake to do the cystoscopy. Urology issues, will a urologist refrain from a cystoscopy in a patient suspected to have bladder cancer in case of a negative test? I don't know. I would probably always do, if I suspect a bladder tumor, I would always do a cystoscopy. Another question, will you refrain from the cystoscopy in a patient that you know has had low-risk tumors and will have a follow-up test that is negative? Well, that might be something, provided the test has a high negative predictive value. And then urology and patient issues, what should that negative predictive value be? Is it 90% enough, 80%, 95%? So those are issues that have crossed my mind preparing this session. Having said that, I will go on with the next presentation, with this actually the results of our European multi-center study. I do have some conflicts of interest. I've been working with the company since this year, and you see below there, fortunately there are some new therapies coming, which is good after a lot of years. So I'm happy that I have some conflicts of interest after many years of no new developments. What about biomarkers in general in non-muscle invasive bladder cancer? You have DNA markers, RNA markers, genes, proteins, methylation, tumor-associated antigens. I already told you many are tested, many are reported, only very few are used. Examples of the one that are used and approved are the NMP22 dipstick test, which is used in Germany as far as I know, even for screening in high-risk patients. BAS-F is using that test. And the FISH test is using in the US, has been used in the US, as a predictive test because everybody thought, everybody had the impression that the positive test does predict a future recurrence, but it's an expensive test and it's relatively labor intensive. So what about methylation? Well, DNA methylation does change gene expression without altering the underlying DNA sequence. And typically hypermethylation of tumor suppressor genes occurs and hypomethylations of oncogenes. And in bladder cancer, methylation indeed has been related to progression to muscle-invasive disease of primary non-metastatic, non-invasive tumors, and has even been reported useful in hematuria patients, so testing for a diagnostic purpose. Let's go to the first bladder cancer papers for methylation. It's done by a Dutch group led by Ellen Zwarthoff from Rotterdam, and they had a discovery set of a fair number of patients and a validation set. They checked methylation of 4 genes to predict progression in TA tumors, which of course doesn't happen a lot. They found 77 patients with progression, and you can see that these methylation markers did very well. Low methylation was very good, very low progression-free survival. You see the difference in the curves, and high methylation was not very good. And they were able to indeed already make 3 distinct risk groups based on this study with a progression-free survival of 8, 29, and 63%. So that seems to be feasible and clinically relevant. And then going one step earlier, even hematuria screening, they also did that. It's the same group of investigators, again from Rotterdam. They used 154 hematuria samples, some with and some without bladder cancer. They checked not only methylation, but also mutation of some genes. And the result was that methylation did best, and with methylation, they found sensitivity together with mutation of 97% and specificity of 83%. And they predicted in a population with a bladder cancer prevalence of 5 to 10%, which would make sense, for example, for your follow-up population, the negative predictive value would be above 99%. So these figures make sense. It has to be replicated, it has to be confirmed, but this would be something that you can use. So methylation seems to be a valuable test, and let's look at what we did with the Bladder EpiCheck test. The usual approach, you know that, is that you assemble a panel of strong markers. You do a fishing expedition, you find a lot of strong markers, you combine those strong markers into a test, but then the problem is that sometimes, or mostly, those markers are overlapping. So they don't really add up. What Nucleus has done, they assembled non-overlapping markers, some with a lower sensitivity, but some with a higher sensitivity, and that resulted in additive value of each additional marker, and that allows identification of different subpopulations. And their biochemical platform, and now I'm of course going into trouble because I don't know anything about it, but the company gave me this slide. What I understand from that is that they are able to identify a tumor cell within around 150,000 cells in urine. So it's a very sensitive test. What do we do? It's a real-time PCR test, so that's not new. We made a selection of 15 DNA methylation markers. So 15, not a few, but 15, it's a test set. It will give you a score, the EPI score, which is a number between 0 and 100. So that's the quantitative test. Sorry, the qualitative test is calculated by a software algorithm, and it represents the overall methylation level of the sample at the panel of biomarkers. And then you also get a positive-negative score, and positive means that the EPI score is above 60. So you will both get a yes-no score, and you will have also a quantitative score. You just have to provide at least 10 mL of urine, so that's easy. We've done the test. Almost no of the patients will have a problem producing 10 mL of urine. Then you can leave that on room temperature for even a day, but you have to ship that at 2 to 8 degrees to the laboratory within about 5 days. That will be processed there, and then you will get your EpiCheck report. So again, it's an objective test, it's operator independent, and it has actionable results. It's really a standard and reproducible method of doing the test. There's been a first cohort that hasn't been published yet. That has been done in Israel, where the company is originating from. And they found a 90% sensitivity in, again, follow-up situation and 83% specificity. Here you see that sensitivity increases with grade. You see that here. And in regard to stage, almost all patients were detected. And here you see that it has a very high negative predictive value. This initial study, the negative predictive value, this study had 18% of positives, is 97%. So that really makes some sense. Also, there was a higher AP score depending on the stage of the tumor, TA, T1, T2. You see that the score increases. So we followed that up with the European multi-center study with centers, 2 centers from the Netherlands, center from Spain, center from Israel, and center from Germany. Tests were done in both Israel and in Germany. 5 centers, 2 labs, one in Europe and Germany and one in Israel. We did that in a little bit more than 1 year. And we used the clinical diagnosis as golden standard, which was cystoscopy, cytology, and pathological confirmation of a tumor, or when the treating urologist actioned on something that he says, so a clinical decision. That was also considered positive. In all, we had 440 patients, of which we could use 353. Some didn't have a result of the test, insufficient DNA, damage of the sample, some things like that. In some patients, we didn't have a definite diagnosis, and in 7, we had both, so no definite diagnosis and no EpiCheck result. Here you see the population, which is, well, what you would expect for a population of patients in follow-up for bladder cancer. Most of them, of course, were older, 60 to 70, 70 to 80. There you see that you have the predominant number of people, male, female, 3 to 1, 4 to 1. Also, what you see, most of them have smoked or are still smoking, and some had some occupational exposure. Disease-specific information is patients were supposed to be within 1 year of a recurrence. So you see that most are within 3 to 12 months of recurrent tumor. Most of them have been treated for that tumor with or BCG or mitomycin C or something different. And you see that here again, the population is what you might expect from non-muscle invasive bladder cancer, TA low grade, TA high grade, T1, 1T2, carcinoma in situ. So these figures are not really surprising. That is what you would expect from a cohort that is a follow-up for bladder cancer. If you look at the results of cystoscopy, cytology, and pathology, you see that some had a positive cystoscopy, some had, of course, positive cytology, and 40 in all had positive pathology. So what has been taken out was checked, and indeed was bladder cancer. Then there were 6 patients that were treated according to other findings by the urologist. So we had those 40 patients, you see them here, that were positive on pathology. TA low grade was 21, and then the rest was CIS, TA high grade, T1, T2. And 6 patients, you see that there's of course not pathology, but they were treated according to clinical findings. Here you see for all patients the concordance between the test and the golden standard, and maybe more important, here you see that of the 353 patients that were the final study cohort, and you see that there is a relatively nice concordance between the clinical diagnosis, the golden standard, and the test. Here, and I think that's probably the most important part of this presentation, you see the results. You see that the sensitivity overall was 68%, overall without TA low grade. And you can of course argue that, but missing a TA low grade wouldn't be my most large concern. And if I see a TA low grade, you can see what it is, and you know what the patient had. I will usually do active surveillance, so I will follow those patients up and not even treat them. So missing that wouldn't be, for me, of major concern. You see that the sensitivity of everything except the TA low grade is 92%, specificity 88%, overall negative predictive value 95%, and overall negative predictive value excluding low weight TA is 99.3%. And I think now we're talking. And then the positive predictive value, but that's probably not where you're going to use the test for, is around 45%. And also one thing that was very nice to see, that there is no influence of whatever subgroup on the test. So whether patients are older or younger, male or female, whether they had smoking, yes or no, occupational exposure, had treatment, yes or no, infection, yes or no, that doesn't influence your test. There's one outlier, that was the University of Tübingen, but they only provided 5 patients, so maybe that's the reason why They have a very small dot there, so I don't think that's really very important. Here you see the ROC curves of the whole population, area under the curve of 0.81, which is already good. The population excluding TA low grade, the area under the curve is 0.95, which even is better. So I think this really makes, from a clinical point of view, sense to use this test. And like I told you, it's not only plus or minus, you can also look at the score per group, and you see that obviously in the worst groups, the score is higher, positive for high grade, positive for clinical decision making. And you see the same if you compare that with the positive predictive value of the score by decile of the test, and the higher the test is, the higher the positive predictive value. So I think in conclusion, in follow-up of patients that you know have had non-muscle invasive bladder cancer, you know what they've had, this test shows an overall negative predictive value already of 95%. Excluding missing TA low-grade recurrences, if you would accept that, the negative predictive value is 99.3%. And in all that, the specificity still is around 88%. So consequently, I think this test could be, at least that's what I'm going to use it in clinical practice, this test should be used in your clinical practice to decrease the follow-up frequency of, for example, cystoscopy. Maybe alternating a cysto with this test, since high-grade recurrences, and that's something you don't want to miss, will instantly be detected with high confidence. I have to acknowledge that there are, of course, some limitations to this study. We don't have, because it was a one-visit study, we have some false positives. We don't have the follow-up of those, so maybe they will get a recurrence. We don't know. It's a limitation. And of course, it is the first, or actually the second study, showing the same results as the first study. But still, I have to acknowledge we did have only 46 recurrences. So going back to what the guideline says, sensitivity is usually higher at the cost of a lower specificity. I think we solved that problem. Benign conditions, previous BCG, etc., will influence many of the urinary markers. It doesn't influence this marker. And in this case, specifically looking at patient on follow-up, I think the results that this test are giving are sufficient to incorporate this test in the follow-up. It is fortunately reproducible, so it's not very dependent on infection or whatever, and that's of course very important. Only thing we didn't solve is false positive tests, and for that we should have had more follow-up, but we don't have that. So that's how we performed this study. That's what the test results have given us, and I'm open for questions if you have any.
So Fred, very interesting and thought-provoking data. The false positives are the thing that I'm intrigued by. So I guess they are just following up in clinical follow-up anyway. So with time, will you know the answer to those false positives?
Now again, the study was specifically designed as a one-step study, okay. So we only did one on the day of cystoscopy. We did all the study, the questionnaires, etc., etc. Okay. And what would be, I think, really, I have to discuss that with the company. I did already discuss that. What would be important to see how that test has performed in those patients that had a false positive test. What their clinical course has been, I don't know.
And then the only other thing, I mean, it looks very positive, encouraging. The slight concern from that first cohort was the fact that you only had 353 out of 440 that had a usable test. So you had about a 20% dropout rate.
Yep.
Did that reduce with time as you learned how to use the test, as you learned how to ship the samples? Was there a learning curve there in how to process these things, or was that the same throughout? Do you know?
No, the limitation was predominantly clinical evaluation. And we did an additional analysis, by the way, for those patients, let's say with an intention to treat. Yeah. Analysis gives you exactly the same results. So the technical problems are minor.
Okay.
Of course, if you don't have DNA, you can't do the test. If you've lost a sample, it's difficult to do the test. But from a performance point of view, there are only very few problems.
There weren't things like have to use your first void, or you have to, do something about concentrating your urine before you void, or anything like that?
No. I think I had some 50 or 60 patients in the study, or more, I don't even know. And they were in the morning, during a cystoscopy, in the afternoon, whatever. So no specific 10 mLs of urine, that's enough. Hugh?
I think one of the intriguing things about this area is that we always quote sensitivity and specificity, but the one thing that there's been very little work on is what do patients want and what would they accept as being acceptable for a urine-based test. I mean, everyone always quotes the Josipovic paper, which says 95% sensitivity, but that's actually quite a small study. And I think it would be interesting to see what level of sensitivity patients would trade.
Well, that's a good question. The Josipovic paper was based on my paper some years ago because Harry Herb mailed me whether he could use my questionnaire. And they found, by the way, 90%. We found exactly the same. We did it in 100 patients on follow-up bladder cancer. And we asked him, you know, you might have missed the introduction, but I did a lot of bladder cancer marker research in the 90s. So then we asked patients, so what do you accept? What should the performance of the marker be to accept a marker instead of cystoscopy? And the result in my hospital, and this exactly the same at Harry Hearst Center, was that it should be at least 90% predictive. And with this test, I think we can do that. Yeah. Mic 2, please. Yep.
Mancini, Padova, Italy. Just a technical question. You said you measure DNA methylation.
Yep.
So I was just wondering, is that free DNA in the urine or cellular DNA?
I haven't got a clue.
I wonder why low-grade
Cellular.
tumors don't release.
Cellular
Because
DNA.
in low-grade tumors it's not so, it doesn't work so well. So maybe it's because they don't release DNA. That's why you don't. I'm not sure it's cellular. I mean, we don't really know if cellular or free DNA that you're measuring.
Good question. I don't know the answer. Maybe
I
Jim
think it
does,
will
or
be an
maybe
interesting
somebody
point
from the
to
company does. I'm not
It'll be
into.
cellular, because if you're processing that urine sample over 5 days, a lot of the cells will have lysed and stuff like that by that stage. So I think it'll be the whole shebang. Here we go, mixed.
Oh, it's
So
a mix. Okay.
That would be
Theo.
cellular DNA.
Okay. Theo.
Fred, you said there were 15 markers in this test.
Yep.
Are there some profiles now? Can you determine some? Can you have some idea about profiles of which of these markers are important for predicting which patient gets a recurrence? Yes or no?
No, we didn't look at sub-analysis of each marker. Maybe that is something that we can look at, but we didn't do that so far. This is really a set of 15 to have a yes or no answer, or a score at least.
Theo, I might be able to, I haven't worked on this project, but I've done a lot of work on the epigenome in my years, as you know. My philosophy is that it is different to gene mutation, whereby you have an individual mutation on this gene and another one here. This is a reflection of the epigenome, and we've looked in a number of cohorts, and always the average index is very prognostic for how those tumors will behave. And I think the actual loci are not that important. What you're doing is picking up changes in the epigenome that are to do with epigenetic instability. So it's really a measure of altered gene. And you'd probably get the same score if you did a whole genome array and did an average differential expression of, you know, what the variance from normal is. So I don't know if the actual specific genes are that important, other than some of them are more susceptible to earlier deregulation than others.
And you say, well, we missed the TAG1. We are not interested in that. But because you want to delay the cystoscopies or postpone cystoscopies. But if you have a cystoscopy, you have a small TAG1, you do active surveillance, but you can also do in-office fulguration, laser. And if you wait and you postpone, it becomes a big TAG1. You have to admit the patient for the TURB. So what do you think about that?
Well, I don't have office fulguration, so that might be a good alternative. I do active surveillance a lot, which means that you can postpone a TOR for maybe a year, maybe a half year, maybe 1.5 years. Patients are very satisfied with that. They see, of course, their own bladder on the video screen. And I'm very sure that I have prevented I've prevented bladder scarring and admissions and surgery and anesthesia. So for me, it's worthwhile. It reduces my workload because I've got enough TORs. I think it's cheaper, and in all, I never have had a patient in which I waited too long that he got an invasive tumor. So I think it's really a safe concept. Okay, Johan.
Yes, I would like to ask, you mentioned the test that you did to your patients that what do you think is the percentage of that you would accept not to find your tumor? No, it's 10%, no? Or 90%?
Well, that's what the patient said 10
Yeah,
years
but
ago.
what did you ask to the patients? I think if you ask to the patient, look, we are looking for tumors, this is low-grade tumors, nothing will happen. If we meet some of them, probably they will accept a lower ratio
Maybe, yeah.
and less cystoscopies.
Yeah.
It depends on the kind of question and the importance you give to miss a tumor or not.
Absolutely.
I
And
think
when I did that test, and Harry heard it the same, we suggested that cystoscopy had 100% sensitivity.
Which
And
is
that
wrong.
That was 20 years ago, and now we know that's not the case. So I realized that it's different. But
And
still,
probably also it depends on the question, the way you do
Sure,
So
sure.
if you miss a 2 millimeters low-grade tumor, nothing will happen. So,
and still I see patients.
but you are doing surveillance, so nothing happens.
Yeah, but still, Joanne, I see patients that have they're free for 2 years, they get a small recurrence, they're really distressed about that.
Okay.
So they're eager not to miss something, at least in my practice.
I don't know if Rick Bryan's in that room, but in the UK, Rick Bryan did a survey. It was much more 99%. They wanted an accuracy of 99% plus for the test before they would replace cystoscopy with it. The other thing is about the anxiety is that this involves an element of recounselling by us. We know in the UK, and Hugh has got a presentation here, where we are looking at early discharge of the low risk patients. And traditionally, we've been told this is impossible. Andrew may speak as a patient advocate. This is impossible. Patients don't want to be discharged. But actually, if you counsel them properly and correctly, as long as they feel safe and they understand there are ways back in if they are concerned, then patients are happy with that. But they don't get that message. They get the message that you have to have a cystoscopy, and they feel that's part of the care package.
Yeah, well, in the UK, of course, the initiative to reduce cystoscopies is, of course, finance. And then, of course, you can
And
convince
quality.
then, of course, you can convince your patient that that was the right decision. I don't know about that. And I can convince some patients to reduce cystoscopy frequency. But most are very eager to have their bladder checked, absolutely.
I think from being a patient myself, I can speak to this quite clearly. We speak to a lot of patients all over the UK and across Europe. The patient community at the moment believe, because they're told that the cystoscopy is the gold standard. So unless we get told different, we presume that's 100%. And you said that's what was believed. So there's
Was believed.
Yeah. So there's a sort of false belief that anything less than that, you're putting yourself as a patient at risk. So if you ask the patient, would they accept 95%, 97%, I'll say, I wanted at least that. But if they're then told that the cystoscopy is actually just 80% or whatever it is, and then you offer them a non-invasive test for 90% accuracy, they'll jump at it. So you've got to actually frame the conversation in the right way, because patients have to understand the reality of the risks.
Yep.
If you believe that the surgeon looking through a camera is 100%, you will never accept non-invasive test. But if you carry on with that conversation, that limited conversation, you will have a massive amount of over-treatment and the actual emotional and the financial burden, but massively the emotional burden of having to come into hospital for an inpatient treatment for something which could, if we had an honest conversation, might at least reduce the amount of times you have to come in, even if it doesn't get rid of it completely. So it's about having that open and honest conversation.
Yeah, well, I think it's a very good remark. And, I don't think we're not honest, but we never really, until we got better imaging methods, like blue light, like better cameras, etc., that. So we never realized that we missed so much. And if you look at the oldest series with blue light, and I did those in the beginning of the century, with white light, flexible, rigid cystoscopy, we miss about 25% of tumors. We never realized that. And of course, that's better now. It's video controlled. You've got a screen. You've got a better scope. But still, it's by far not 100%. And in that respect, this test might even do better. I don't know. But it's in the same range. So it's a realistic alternative. And I totally agree that if you inform your patients, not honestly, because we don't know better, but correctly, as far as you know the science in 2018, I think it's a realistic alternative. Okay, Jim.
Thank you, Fred. A lot of that discussion will lead neatly in here. So I guess some of this is repetitive, but it's sort of hammering home the point, I think, for ourselves. There's my conflicts. and nucleus is obviously the one that's key here as speaker fee. So I think I would perceive we do need to change the situation in bladder cancer this year, currently for the future, because I think we have problems with it. These are the UK survival data for the disease, okay? So we focused a lot on non-muscle invasive disease, but what drove us in the UK was that the outcomes from aggressive disease are not improving the way we would like. Centralisation has made a big difference in the UK. That may or not be applicable to other healthcare scenarios. But fundamentally, we aren't improving the survival of this disease, which is, in contrast to nearly every other solid cancer out there at the moment. So we feel that things need to change. This is the outcomes from cystectomy in Sheffield year on year, and you see there is no real trend. It's all over the place. So it doesn't really help us at the moment focusing so much time on this disease. This is the same graph as you showed, Fred, and again, it reiterates the point about the cost. And I think partly that is because we are spending the money in the wrong place. So this is the cost versus the mortality rate. We spend the vast majority of the cost on bladder cancer monitoring low-grade, low-risk disease, and very relatively little on chemotherapy and radiotherapy, where all the mortality occurs. So we have to somehow change that shift that momentum. And I think a urinary biomarker like this gives us further opportunity. Why is it so expensive? Why is it so difficult? It's because it's so complicated. This is just the diagnostic pathway. We know we have hematuria. We're bringing together a number of specialties together. And that's, if you find someone who needs, thank you, Fred, more aggressive treatment, then suddenly you're going to have a whole range of other choices that come their way. So in the UK, even in what we think is a target-driven culture, this can take around 100 days on average now to go from the beginning to the end. And I think that must be contributing to part of our story. And then afterwards, when you look at the recurrence rate and the progression rate and the surveillance, again, we're looking at huge amounts of resource and infrastructure to look after a disease that probably doesn't kill many people after the first phase and the first rationalization. And that leads to poor quality of life. So this is the NHS Patient Experience Survey. This is a survey across all people with cancer, a sample from all of them. And what you find, as you'd expect, is the urological diseases do badly. And maybe that's partly because men have a slightly poorer affect, whereas women don't. But predominantly it's to do with the fact that there is a lot less interest in this end of the disease. And there's a lot of repetitive cystoscopy and follow-up with limited impact on their survival. And if we look at, so that's patient experience. If we look at their patient-reported outcomes, so this is to do with how happy they are, we see that a lot of them have problems with self-care, a lot of them have problems with mobility, and those lead to problems where you have to come repeatedly to and from hospital. So I think all of this feeds to a culture where we have to think about changing how we manage some patients with bladder cancer. If you add those up together, that's what you get. So my focus has been often, at the moment, to try and shift it away from the green, the low-risk disease, and shift our energies onto the yellow and the red disease through trials, improving treatment. And thankfully now we have new drugs, new advances, that this is actually now happening finally for bladder cancer. But we have to refocus our effort, I think, slightly off the green situation here. We've looked at this work and we took low-grade cancers and we found very low risks of recurrence. And that matches what we see elsewhere. So this is the Swedish data where they look at pun lumps and low-grade papillary urothelial carcinomas. They represent about a fifth of cancers at diagnosis, and they have high rates of local recurrence in the bladder, 50 to 60%. So they're going to recur, Theo, if you follow them long enough, okay? But very few progression rates. This is the Sheffield cases, so again, it represented about 20% of our workload. Our recurrence rates were very high, but our progression rates were very low, 2.3% over the first 10 years. That was progression to upstage and up into invasion and then subsequent metastasis, etc. So it's low, and of those, you could break them down into a third where we got the diagnosis wrong up front. They clearly had an aggressive disease, and this is effectively the same as the false negative cystoscopy. We've missed what we were treating. Some gradually got worse over time, but a significant number, a third, we heard nothing from for 5 years, then suddenly the disease got worse. And when you spoke to these patients, they were having problems. They were having hematuria, they were having urinary symptoms. But because they had this annual cystoscopy, it didn't occur to them to tell their doctors that things were getting worse on the way through. And our data are nice in they match a lot of other series almost identically. So our disease-specific mortality was 2.3% at 10 years. That's almost identical to the Swedish data at 2.4%, identical to the US data at 2.8%, and very similar to Shirok's data from across a number of European sites at 1.2%. So it's a low event rate, and this is very similar probably to the survival from low-volume Gleason 6 prostate cancer over time, and low aggressive early-stage renal cancer. And we're very comfortable watching those much less aggressively than we do in bladder cancer. So I think the time is right to do that. I'll just shift. And when you break it down economically, it turns out to be a hugely expensive resource, and that's why we have these problems with the cost. So for all this triage from our initial cohort through, for all the effort, we saved one life by all the surveillance we were doing in our 2.3% mortality rate. It took 7 cystoscopies, flexible cystoscopies, to find a recurrence, 147 to find a grade progression, between 375 and 675 to find a stage progression, which effectively meant we were spending about £2 million to save one life. And that is a simplistic quote. That doesn't account for all the extra burden on patients coming to and from hospitals, antibiotics for urinary infections, admission for hematuria, pain, all those things you can imagine. So it's a lot of money that we are not spending elsewhere that we are spending on this disease, and it reflects time and effort. So in NICE, we recommended much earlier discharge. So discharge at 12 months if you're stable. But for many reasons, this is not necessarily acceptable and has not been adopted by many of our patients. In Sheffield, we worked together, we worked up a compliance pathway, and we found that we were saving 30 cystoscopies per month if we adopted that pathway. And our patients seemed happy. We did patient surveys, there wasn't much decision regret, people were happy with it. They came back in, and with time, some of those patients will have cystoscopy. They're not lost forever, but we are trying to shift the burden elsewhere, okay? But as Hugh will show in this meeting, when we do a survey across the UK, less than half of my colleagues have adopted this because of the things we talk about, Fred. They are uncomfortable with the concept of discharge. Patients don't feel comfortable with it. And it's something new that's different to what we've done before. So people are unkeen on that. So perhaps somewhere there is a middle ground that we can come up with, and that's maybe where urinary biomarkers could be there. If we look at the burden, so Fred, your fantastic guidelines group, and the whole guidelines in general, if we look at what they recommend for intermediate risk non-muscle invasive disease, this is the number of cystoscopies you should have over the first 10 to 15 years. And it's quite a burden if you think about that, especially if you are traveling a long way for the patient, especially if you're elderly and you already have mobility issues or something. So it's quite a burden that may not necessarily affect their outcome, especially if you look at these event rates, they are stabilizing by 5 years or so, if not sooner. So, do we need to follow on lifelong? Do we need to reflexly do an annual cystoscopy? I don't know. But what about biomarkers? So up to date, Fred did a very good summary. I think the perception of many people is that historically they have been unreliable. They are not as good as we think. And when we hear from patients, maybe 90% in the Netherlands, certainly in the UK, if you ask the patients and you give them the impression of a fantastic cystoscopy, they want a very high rate, 100% accuracy or more. And they're expensive because often they merely duplicate the effort. Nearly you always have to do cystoscopy at the same time. But I think there are some opportunities, some low-hanging fruit, where maybe we could work together to try and bring them in a way that is safe, is acceptable, and probably is cost-effective, okay? So that's the way we work it. So if we take low risk, this is the current guideline option. This is cystoscopy to 5 years and then discharge at that stage, depending on demand. So what about using a biomarker to alternate? So Fred, we have a discussion at this stage. What would you think of that approach? Would you be comfortable with that for your patients? Okay, should we have a show of hands? So in the room, who would be happy omitting alternate flexible cystoscopies in a patient who was asymptomatic and then swapping it for a biomarker? And if the biomarker, nuclex in this case, was positive, you would then do an on-demand cystoscopy. So put your hand up if you would be happy with that approach. Okay, and then put your hand up if you would be unhappy with that approach. So only one, which means I have to ask you why. Yeah. Oh, he wants to go to the toilets over there. So I can understand some patients would be uncomfortable. Andrew, could I ask you as a patient, what would you feel about that approach? So this is in low-risk disease first.
I think if we had the correct conversation, then it would be acceptable. The problem is at the moment is that there's 7
Okay.
that if you get stopped at any point, you're taking a big risk.
Yeah.
And that's the zeitgeist out there, because that's what we're told by everything we read and talk about without any guidance from you guys. So you've got to change the conversation so that we realise that this burden that we accept isn't really giving us any benefit or very limited benefit. But at the moment, we can see without regular hospitals for life, people that are getting the worst treatment. That's the massive amount of over-treatment.
Okay. So I'm going to look at some people in the audience. Yuan, can you stand up, please? Do you perceive that in Spain, low-risk patients are happy with, do you use active surveillance at all? If you find someone who's had a low-risk tumour, you look in, they have a smaller piece or they're asymptomatic, would you just watch them at that stage, or would you think, reflex, I should TUR or cauterize and remove all burden?
To be honest, I don't know exactly, but what generally speaking are doing in Spain. As you know, there are a few groups doing active surveillance. And also there are centers that do just small recurrences for outpatient fulguration, which takes a few minutes and that's it. So there are exactly how many groups are doing one thing or the other, I cannot tell you. Okay. What I can tell you is that a lot of people, I think in Spain, we are following these low-risk groups just with ultrasonography.
Okay.
And nothing happens. So, and we have not published it, but we have promoted, and really just following these patients with really low-risk, low-grade tumors, ultrasonography. If you not detect a 2-millimeter tumor, nothing happens. And when it's 5-6 millimeters, you see it, and then you treat it. So, and I think this is an option in a urinary marker meeting, probably, or to combine in the future. I don't know exactly which methodology, or to combine ultrasonography plus marker or whatever. I don't know, probably.
Okay.
But
basically,
I don't have the evidence, we haven't published that, so, but nothing happens. But there are also 2 studies, I think, 2 Danish studies they published following patients with ultrasonography compared to cystoscopy. And
But if you do cystoscopy, do you combine that with cytology? Because you might miss CIS or...
Yes, we,
Okay,
in
so-
low-risk group, it's just ultrasonography. In intermediate risk group, we combine every 6 months ultrasonography and cystoscopy cytology.
So it's basically a similar schedule as doing a test with a high negative predictive value, but then with different means.
No, probably using a marker with a high negative predictive value, you don't need to do ultrasonography, you need to do cystoscopy and nothing. I mean, with a very high negative predictive value.
Now, let me, I have some doubt to use urine test in a very low-risk population, because if you look at the first line of the ERTC trial, with the patient with recurrence score 0 and progression score 0, so this very, very low-risk population. So which is the adding value of urine test in this population during surveillance? Probably we can change the cystoscopy interval without adding any other test, because the 15% of the most of the recurrence is during the first year. Yeah. After the first year, there is so if you use 3 months cystoscopy, 1 year cystoscopy, and then after 2 years cystoscopy, we can.
Yeah, I think the only reason I pick on this is that we tried to change the cystoscopy interval in this cohort from once a year to never again, and it wasn't really accepted by patients and doctors in the UK. And okay, every 2 years, but you know, there's good work in other cancers that show that routine follow-up actually can lead to worse outcomes, because patients develop symptoms of a problem and they go, well, I saw Dr. Witches last year, he said don't worry about it, and they don't represent to you. So actually, in other cancers, there's good work to say what you need to do is educate patients about the symptoms you would worry about, and then ask them to present earlier with those symptoms rather than ignore them and wait. And so we thought in the UK that may be the better model to try and educate, but it doesn't seem as acceptable, whereas something like this, I think people would still feel under a safety umbrella about that sort of thing.
He's first, actually.
Sorry, I was just having my supper earlier on.
Okay.
Sorry.
So he was the yes earlier.
I was the yes, because first of all, I'm from the UK and very happy using the best nice recommendations for low-risk groups. We see them 3 months, 12 months, no recurrence, discharged. So I'm very happy with that, and our patient population seem happy with that because we put it them early on that that's what they expect, and that's what we do, and educate them about when to come back to us. My understanding is that all these biomarkers, the sensitivity is much lower for picking up low-risk tumours, and so really, if it's a low-risk tumour, the biomarker isn't going to pick them up anyway, and if you are going to look for something with cystoscopy or ultrasound, you want something that's small and easily diathermable, so I don't think they're going to add anything in the low-risk group.
I think the only thing is that once you start doing this to populations, then the 1% progression risk suddenly becomes 100 people, you know, and so this is a way of trying to maybe reassure that's the case. Now, I suspect those 1% would be having hematuria and a change in their urinary symptoms or something like that would help trigger it, but,
Yeah, so just explain myself rather than hide
No.
the sandwich.
Andrew.
I think that we've got to look at the actual discharge protocol for any patient, no matter whether they are low, intermediate, high risk, or even muscle invasive. Because at the point of discharge, you've got to actually counsel the patient and then counsel the GP of what that actually means. So it means that they have to be told and empowered about what to look out for so they can actually come back to you. Because what this isn't is about goodbye, we'll never see you again. It's about empowering the patient to actually be aware themselves of what symptoms that they might get so that they can come back in to see you guys. Because that should happen all the time, because there's this false sort of belief that by checking on this regular basis that you can ignore it in between times. I mean, we do know that patients need to be empowered so that if there is a particular symptoms they're getting, they should come back to you between checkups anyway. So, but it's about empowering them with the right information so they can be part of their surveillance. That's where you'll get the better response, because they'll be there in front of you at the right time rather than waiting for that year interval or 3-year interval or whatever we say in the chart.
So if I take another model, so let's move off in low risk. I think low risk is probably the low-hanging fruit in that I agree the biomarker will probably be negative, but I think it is the group that is safest to trial some sort of biomarker in because the event rate is really in your favor. But if we go into the bigger population, which is intermediate risk, and of course there are high and low intermediate risk, and there are ways to risk stratify. But again, currently this is the EAU guideline approach. And I wonder either about an alternating strategy, where you save maybe 9 cystoscopies, or a swaps strategy after a period of time, whether that be 3 to 5 years. My worry about this sort of strategy is that this is where the false positives become important, Fred. I know Ellen Zvortov did the Uromol study, where they did a study prospective in Rotterdam, I think it was, where they did urinary biomarkers in one arm and cystoscopy in the other arm, and you got on-demand cystoscopy if you were positive in that arm. The problem was the biomarkers were positive nearly all the time, and at the end of the study you had far more cystoscopies in the biomarker-driven arm than the control arm, because actually these people have got field change. Perhaps they have field change that's not quite amounting to a cancer, and we don't understand the biology enough, but there are some molecular changes that certainly don't ever propagate through to a malignancy. And this is where the false, whilst when you're looking at diagnosis, it's the negative predictive value you want, i.e. if the test is negative, are we sure they don't have cancer? And this is 99% if you look at high-grade disease. But in the long term, you also want some specificity, because it means that if the test keeps going positive in patients who don't have it, you're going to be bringing them back just as much.
Yep. Oh, that's why we want to know what the results are of the negative, positive predictive of the false positives.
So should we have a show of hands in the room then? So, I mean, you don't have to agree with us, but would you feel comfortable in a more higher risk population, so intermediate risk here, so not high grade, not T1, but probably relatively high volume, low grade disease. So if you look at the ERTC, you know, more than 3 centimeters, multifocal, maybe some recurrences early on, but nearly always low grade recurrences. Who would be comfortable in sort of alternating cystoscopy for a biomarker in that setting? So much less so. And who would not be comfortable with alternating a biomarker in that setting? Okay. And the rest of you are to be convinced. What do you think, Fred?
I think it all depends on the performance of biomarker. We're just asking imaginary study. I would be happy taking biomarker in any scenario if it performs according to the needs that I need in that scenario.
Well, you were late. You missed in so we have the biomarker pilot study that's shown at what is negative predictive value 99%,
Or you said nucleus as a biomarker.
Yeah.
That's a different than a biomarker.
Okay. Well, or this particular biomarker.
Okay, sorry.
So, Shirok, what do you think about this?
I think in this scenario, I think I haven't seen the presentation, but it depends what you expect in this scenario. You want a high negative predictive value. That's the one thing you care about mostly, right? And the nucleus does very well in this scenario for the low-grade cancers. So it's probably, and even if it's not 100%, if it's 80%, 85% in an intermediate risk, you're happy with that. In the high risk, it's different. In the low and intermediate risk, you're fine with 80% above. No?
I think we want safety for patients, right, but we also want to try and improve or reduce the burden of surveillance on them. Okay, so I'm going to close there and let sort of wrap up. Let Shirok come in. Is Shirok next? Yeah. So I think there is an opportunity here. I think you can pick safe cohorts to trial biomarkers in. I think we have some interesting models where we could try and reduce the burden, and I think mostly we would still feel comfortable with that. And I think patients would buy into that because they feel that they're still going to get that surveillance and they're still going to have the gold standard, but if they're doing it less often. So I think there's an opportunity to go from. So thank you for your time.
Thank you very much. I apologize. This meeting is you're running left and right. You barely know where you're going. But I think when they asked me, would you look at the data and tell us if you think this is a good biomarker. That's how our relationship started. The company asked me to look at the data as sort of an external person that was not involved in the trial, that had nothing to do with the design of the study, and would have a critical mind, try to see, is this biomarker, could this biomarker potentially have a clinical utility, not only in an abstract way, and I hope in the next few minutes I can convince you that that is the case for this biomarker. These are my disclosures, as you can see, quite promiscuous and working a lot on biomarkers. So to set up the stage, and I'm sure Fred already talked about this, the main issue in bladder cancer, there are many issues, is that not only it's a disease that is quite demanding on the patient and his family and their surrounding, but also as a public health and socioeconomic issue, and that is where specifically non-muscle invasive, it's driving the cost of care dramatically. This is due to the frequent cystoscopy, high rate of recurrence, and a chronic disease. We are unfortunately failing in delivering what we promise our patients, that is a better care, a better survival, a better future. Survival has kept the same. The number of interventions we're doing is quite too many and are not serving our patients well. So I think we are failing to a certain degree because we have limited awareness of bladder cancer, and I think I'm very happy to see from an advocacy group somebody be present, being proactive, because this is in bladder cancer, and thank you very much. We have very few in bladder cancer that are doing this, and the awareness is very important. But certainly the two issues a biomarker can address is the diagnostics. The diagnostics at our moment neither effective or cost effective. The therapies are definitely not effective and cost effective, and I think one of the major issues we have in bladder cancer is the follow-up. The follow-up, unfortunately, is not effective or cost effective, specifically non-muscle invasive bladder cancer. And limited new developments, but that's going to change. So the goal in non-muscle invasive bladder cancer is certainly, and this is what we start with, eradicate the cancer. Prevent or delay the tumor recurrence, prevent or delay the tumor progression, these are the important things, prevent the panureteral disease, and preserve the survival. But we never ever talk about the fact of the multiple cystoscopies, as Jim Cato said, and what we are doing actually to do that, to achieve that, and the over-diagnosis and over-follow-up we're doing. Unfortunately, our diagnostics, as I said before, are not adequate for this disease because our gold standards in cystoscopy and cytology are good, but not good enough. They're invasive, they're expensive, and they're time-consuming for the patient to come on a regular basis to see you, and for you, the procedure is in the office. For the urologist, in many scenarios, it's a good thing because it drives them money, but it's certainly not the right thing for the patient. And the problem is, despite all this, our diagnostics are not perfect. We have still a false negative rate that is pretty significant, up to 20%, and that's what we see from the blue light studies. So, the promised land of biomarkers. Biomarkers will change everything you do. And for 30 years, we've been all working on biomarkers, and we have not found a single biomarker that can make that difference. Because there are some benefits you expect from biomarker. Certainly in certain scenarios, in a non-muscle invasive, you hope that it will reduce your frequency of cystoscopies. You also want to identify those patients that will get progression, but before they have a full-blown progression, so you can intervene early on. Or get them even in their progression at the earliest stage, so it's not metastatic and you lost the patient. By achieving these benefits, you not only will improve quality and length of life, but you also will reduce cost. Now, the downside is this biomarker needs to be a good performing biomarker, because if it doesn't perform well, you're losing safety. You miss recurrences, and on the other side, if a biomarker has a low specificity, positive predictive value, you might even increase your number of interventions, unnecessary interventions, right? And driving anxiety and cost for the patient. Unfortunately, up to 2018, and we've done a bunch of reviews, and we are in the guidelines, Juan Palu and I, and we think of it, and Hugh is as well. And unfortunately, there's no biomarker that has entered any of the guidelines. Because, yes, most of the biomarkers that so far have been used, the sensitivity is superior to cytology, specifically for low grade, because cytology doesn't perform in low grade. And I think the question is, in low grade, at all, do you need a cytology in a follow-up of the patient? Because the progression rate of a low grade is very low. But at a population-based level, this is another question. Specificities of most of the biomarkers has been lower than cytology, and there's no single biomarker that is superior to cystoscopy with cytology. So there is no good ideal biomarker to date. It is because we have asked the things to a biomarker in the wrong question. The performance of the biomarker you expect is according to the clinical scenario. For example, if I have, it's not a one-size-fits-all. In a screening or early detection scenario, that means a patient comes with macrohematuria to you, or a screening population, let's say we identify a high-risk population, heavy smoker, long-term, and you put it in a screening. There's no screening that is yet recommended. What you expect is a high negative predictive value. You don't want to miss a cancer, so you want 100% probably negative predictive value. But in the surveillance, that was what I was saying before to Jim, you expecting a negative predictive value, but you starting to squeeze that you want a positive predictive value because you don't want to do unnecessary testing and lower the recurrence rate. And even if you miss a cancer, who cares in a low grade? Because in 3 months from now, if you're going to do a cystoscopy interval, you're probably going to get it. And that cancer will not change the biology and will not be life-threatening, right? But in a high-grade cancer, there you want the negative predictive value as well, because in 3 months from now, if you miss it, you're going to have a serious problem. This will advance a stage, your metastatic rate will increase, and you cannot save that patient. So the 4 questions I want to address is, what is the true diagnostic performance of EpiCheck? Does it improve our predictive accuracy beyond, not only in an abstract as a single biomarker, but adjusted for all the clinical factors we know today? And in clinical scenario, we're using factors. What was his previous cancer? What was his frequency of recurrence, and so on? And is its performance affected by those features? And how will it change our clinical decision-making? So we received the data graciously from the company, from the trials that Fred Witt just did, and a very external view, without having any insight of what analysis they had done before. We looked at the data and we set our references for a positive test or for a positive endpoint a little bit different than Fred did. We said positive pathology is cancer, but also positive cytology is cancer, just it was missed on the cystoscopy because cytology is by definition, a positive cytology is cancer. So we took it both, and that makes a discrepancy of approximately 6 patients compared to the data that Fred showed you. What did we find? For detection of any cancer, we find a 94% negative predictive value, which is very good. The positive predictive value was a little bit around half of the patients, so a little bit of unnecessary testing. But we also asked the question, that is the clinical question, are we going to miss high-grade cancer, which is the most important cancer to look for because that you definitely don't want to miss. The accuracy of the test was 85%. If you look at high-grade cancer, the negative predictive value goes almost close to 100, 99%. Now, you're going to have a positive predictive value and do a few unnecessary testings that are going to be, but you're going to accept it in this scenario to not miss the high-grade cancer. The accuracy increased for high-grade cancers, those that you're looking for, up to 80%. So does it improve our predictive accuracy? Now I show you these numbers, you're going to say, well, it's good test. But what if it's just measuring something we already know? From the previous stage of the cancer, from its recurrence, something that a nomogram or a mathematical model could predict us already without adding this test. So in univariable analysis, we looked at the data in 2 ways. We looked at it as an EpiScore test at a cut point, or we looked at it at a continuous variable. So using the cut point, a 15 times in univariable predictive accuracy for predictive odds ratio for detecting cancer. Now adjusted for all the variables that we know and have from the past from the patient, those tests not only keep the performance accuracy or the odds ratio, but it's quite significant compared to anything else. Not only they're the only significant variables to predict in addition to the previous frequency of the cancer recurrence or the time from the last recurrence, but it is pretty significant and pretty impressive in a multivariable analysis. If you look at it in a nomogram, the nomogram is just there for you to give a feeling of the additive value or the breadth of the test performance. And you see if you put the EpiScore, it's the most impressive predictor of a cancer presence than any other one. Age, gender, the EAU risk stratification, or the time from last TURBT, or even if you had intravesical therapy. So pretty powerful. The base model, so if we today use everything we know about the patient, I could predict you with 60% accuracy if this patient is going to have a cancer recurrence at this cystoscopy I'm going to do. If I add that biomarker, I'm increasing it to 82 to 84, depending if you use the continuous score or as using a cut point. So over 22% improvement in predictive accuracy. There's no single biomarker, and I've done maybe 15 years tests on biomarkers for screening or for whatever scenario in prostate cancer, bladder cancer. I've seen such a big jump in your decision making. So basically what I'm telling you is if I give you all the information that a clinician has today, he's barely above, if he integrates that, barely above of a flip of a coin knowledge or information to make a decision if this patient has cancer now. That's why he does all the frequent testing. But with this biomarker, you're jumping a big difference. Now for high-grade cancer, which is the cancers you want to detect. In univariate, this test performs dramatically. It's a powerful odds ratio if you look at 58%, but a very wide confidence interval. If you adjust it for all the known clinical factors that we know, it stays significant and still a pretty significant odds ratio. We agree that the confidence interval is quite wide, but for the continuous score, pretty narrow and pretty performing very well. Here again, if you look at it at a nomogram, it is the most significant. A jump in the score will give you a lot of increased probability of having a cancer compared to anything else. What is the area of the curve of everything we know currently? 70% for high-risk cancer. And if we add it, over 24% improvement, a big jump. So I think in the current statistics, we can say this biomarker adds significant value to what we already know. So is it affected, its performance affected by patient scenarios? What I want to say here is if the patient is a smoker or non-smoker, will it perform differently? Its additive value to everything you know will be differently. Or if a patient is male or female or any other factor, risk factor, age, anything performs it? No. No matter what group, subgroup you're in, it still improves your predictive accuracy for all cancers up to 80%. And close to mid-90s if you are looking for high-grade cancer. So it's a very stable, robust test, not affected by any other factors. So my last question was, does it improve the clinical decision-making that you will have tomorrow? If tomorrow you go to your office, how many cystoscopies will you save if you use this test? And how many cancers will you miss if you use this test? What is the risk associated with it? So if you look at it, we already said before that, Fred, I think you presented that, the AUC of this test. We have used a little bit different definitions, but the AUC is pretty good. It's the area under the curve. If you use area under the curve, it's good, but what does it tell you for your clinical decision? The problem with the AUC is it does not adjust for the prevalence of the disease in your population. It might be in certain populations that are referred to Fred or my clinic, these are a little bit higher, more frequent cancer recurrences or different non-muscle invasives as one sees in a community or different regions or different countries, smoking affecting it and so on. And the AUC does not adjust for the sensitivity and specificity you care about. Because I told you just before, depending if the patient had low-grade cancer or high-grade cancer in the past, you will expect something else from the negative or the positive predictive value of that clinical test to implement it. So there's a way to adjust for that, and it's called clinical decision curve analysis, and that's where you wait for the prevalence, and also you wait whether you like more sensitivity specificity, that's a statistical model, and you also can vary your threshold probability. What I mean with that? For me, if a patient comes, I will ask him, how worried are you about your cancer coming back? And you have your anxious patient, he's going to say, if I have 5% chance of having cancer, I want a cystoscopy. And I can tell him 5%, don't worry about it. But he wants the cystoscopy. But there's going to be another patient who's going to tell me, I want the cystoscopy, only it's a 15% chance of cancer. Because I'm more relaxed. So it's going to be how risk averse are you, even though you explain to the patient the probability, so you can put your threshold where you want. So this is what we do, including that in the decision curve analysis, how many cystoscopies can we avoid while not missing a single cancer using nucleics, EpiCheck. So this decision curve is quite complex to explain, but this is if we would cystoscope all the patients, and we're looking at the net benefit. If you use your current prediction with all the variables you know today, that I told you before, doesn't change much. You still have to do a lot of cystoscopies. But if you use the EPI score, you will see that actually your number of it outperforms the other tests dramatically and saves you a lot of cystoscopies, and here's the threshold probability. So in numbers, I know those curves are very complex to understand. In numbers, to make it a little bit more understandable, palpable for you, if I have a risk, if I have a threshold probability of 10%, so if I say, look, I have a cancer, if I miss a cancer, I'm ready to take 10% risk of a cancer, I want a cystoscopy. If the patient tells us that, I'm saving 36% of the cystoscopies while not missing a single cancer. And that goes further up. You see, you can, obviously, if you put your threshold higher, you will have more cystoscopies avoided. And if you look for it for high-grade cancer, same thing, what you already know is equally to doing a cystoscopy in everybody. If you use the EPI score, you're dramatically increasing your clinical value, saving a lot of cystoscopies. And if I do not want to miss a high-grade cancer, and that is a clinical question that is, I think, at hand and the most important question, with 10% of threshold probability, I'm saving 77% of cystoscopies. If I use this test, and I could forego cytology cystoscopy in 77% of our patients. And if I go higher, even goes to 80 or 90%. So I think this is how this test can help you avoid cystoscopies in a discussion with your patient in a highly accurate way. So in conclusion, I think looking at the data externally, totally unbiased, and actually with a critical view, I was not expecting to see such a good performance. I think it has excellent diagnostic performance with a negative predictive value of 94% for any cancer, 99% for high-grade cancer. It improves the accuracy beyond what we have already clinically today by 22% with any cancer and 26% for high-grade cancer. This is the biggest jump I've seen any biomarker added to clinical scenarios. And it's a diagnostic test that is quite robust. I'm not saying robust how the assay is performed, but robust based on a clinical patient that comes in with his personal features. Being a smoker, female, and so on, it will not affect your test performance. We had that problem with NMP22 and other biomarkers. And then finally, it can significantly improve your clinical decision-making, reducing the unnecessary cystoscopies and cytologies, and therefore, which we have not shown yet, lowering the cost, but it's self-explanatory, improving patient care and quality of life. Thank you very much.
Rock, excellent presentation, and you see you are now out of time, so you're exactly within your 20 minutes. No, that's great. So if there are no questions, we will proceed with the next presentation of Roberto. Yes, sure, of course.
Just one quick question. What about the use of a non-invasive test like this at a primary care level? Would that aid in getting earlier diagnosis? Because most general practice clinicians make a decision of who to refer based on no test at all, just on their basis of thinking, is it male, what is their age? And that's their decision process to decide whether to send somebody for further tests. Is this something that we could use to great benefit for the patient community at a GP level?
I think your question is one of the most important questions. Where we can make a difference in bladder cancer survival is not by using a robot or better chemotherapy, it's by detecting cancers early on. And a lot of problems we have, specifically in females, is the late diagnosis of cancer, microhematuria misunderstood, not referred, and maybe reference done for the wrong reason, plugging up, and the wait time to get a cystoscopy. So this test could be fantastic. The answer to that is we don't know it because the trial Fred did is actually in a surveillance setting. But looking, my gut feeling, I tell you, with no data, and Fred might be better to answer that, is its high negative predictive value in a non-muscle invasive gives me the feeling that you could save a lot of embedded triage the patients, and by a test in that setting could be easily used in any setting, any gynecology, primary care, to select the patient to send, and maybe thereby sending the right patients, and more often the right patients. I don't know.
Yeah, same gut feeling, but again, you would have to look for that. It's a different population with different statistics, so test performance will be different, but would be a good idea to test that. Okay, thanks. Roberto.
Yeah, can I have my slide, please? First of all, thanks a lot for kind invitations with such a great faculty in bladder cancer. For me, that I'm not an expert in bladder cancer. I'm coming from the urological field, but I like the academic work, so I like this to speak about the potentiality of this test. And I try to convince you on using this test in other settings. So what is this? This is probably most of you knows, is the first release Victorinox knives designed for the Swiss soldiers in the late 19th century. And this is a single object, portable, with a lot of functions. And the last release is the Giant. It's a single object with more than 140 different functions in order to to use in different settings. So the question is, what's the relation between this tool and the Bladder EpiCheck? Is this the case? Due to the characteristics, the intrinsic characteristic of this test, may we use this test in other setting? And I try to convince you to use in different settings. Which characteristics? Two, the biomarkers identification process that's behind this test, and the final panel construction process that's behind this test. So they look all the genome in order to find genes or markers that able to differentiate sick and healthy population. Not including only genes known to be related to cancer evolutions. This approach allows for identification of unknown and novel markers. And then they need to put together all these interesting markers in order to build the final panel. And not only considering the best marker, the marker with the best performance, with the high sensitivity, high specificity value, but also the markers that add something to the best markers, without having markers that overlaps one each other. So as a football, I used to play football since 30 years, and as a trainee of football team, imagine you are a trainee of your national soccer team. What do you prefer? You prefer this team with a lot of, probably the best player ever, a lot of masters, or you prefer this team with the mix of class, a mix of running, a mix of physicalness, a mix of intelligence? I have no doubt in my mind as a trainee of a football team, but I leave you your choice. So, which are the potential uses of Bladder EpiCheck in my mind? And I want to share with you my personal thinking on this topic. Steve Jobs said 20 years ago, think different. And I think the real academic work is to think different, to think and to reply to clinical questions in a scientific way. So imagine 3 different scenarios. Patients with high-risk bladder cancer after TURB that needs a re-TURB according to guidelines. This is probably one of the few cases of 2 operations to reach the aim, a distance of 4-6 weeks one each other. So is it really necessary to do a re-TURB? Second scenario is a patient with a suspicion of upper tract ureteral cancer. It needs selective cytology. It needs biopsies. And sometimes, most of the times, they are not conclusive. So may we use something to improve diagnostic performance and have prognostic information? And the third scenario is asymptomatic patients coming to your office with a urine examination showing microhematuria. Are we sure that all of these patients need cystoscopy or upper tract imaging, or we can select patients for further urological evaluation? So coming back to the first scenarios, the EAU guideline says the absence of detrusor muscle in the specimen is associated with a significant high risk of residual disease, and a second TURB can detect residual tumors, increase recurrence-free survival, and provide prognostic information. And if you compare all the guidelines together, you can see that there are minimal difference between each other. Re-TURB is indicated in case of suspicion of incomplete initial TURB, if no muscle is present at initial TURB for all T1 cancer and for all high-grade cancer. And if you look at all the systematic and review and meta-analysis, this is one of the last released on European Urology Focus in January 2018, you can see the extreme variability in the prevalence of residual tumor according to all of these studies. It varies from 20% to 90%, and it's due to a lot of factors that I don't want to underline now. But if you look at this very, very last systematic review with the two of the authors on this stage today, they state that residual tumor is common after TUR for high-risk non-muscle invasive bladder cancer, but the quality of evidence is weak. And what is clear is that there is an unmet need for a large multi-center prospective intention to treat randomized controlled trial on re-TURB for TA and T1 tumors. So the problem exists. So this is the reason why I designed a pivotal multi-center study, start recruiting on January 2018 with 3 centers in Italy and 2 different labs working on Bladder EpiCheck, with Professor Popiglia and Professor Tubero join us in this study. What's the hypothesis behind these studies? Patients with histology-proven superficial high-risk bladder cancer after TURB and positive EpiScore at Bladder EpiCheck test before TURB will have negative EpiScore at Bladder EpiCheck test before re-TURB if they are cancer-free at re-TURB. So it's quite it's difficult to understand, but it's very, very simple. So patient with a positive EpiScore before TURB with high risk that needs re-TURB will have negative EpiScore if they are cancer-free at re-TURB. So the objective of the study is diagnostic performance of Bladder EpiCheck and its correlation with the re-TURB result, and the secondary objective is to study the EpiScore variation before TURBT, after TURBT, 15 days after, and before re-TURB. So this is the flow chart of the study. We enrolled patients with suspected bladder cancer after cystoscopy. They have the TURB. Patients with low intermediate risk or muscle invasive of negative histology excluded from the study, and patients who tested negative, the EpiCheck tests are excluded from the study. All the other patients continue the study, and they collect urine after 15 days after the TURB, and just before re-TURB, they have re-TURB in 4-6 weeks according to guidelines, and then we analyze the statistics. So the results are expected in Q3 2018, but this is only an example. This is the first patient enrolled, the first patient completed the study. So he had a tremendous drop after the initial TURB that diagnosed a T1 high grade with muscle present and complete TURB. They have a dramatic drop of the EpiScore just 15 days after TURB, and another drop in just before re-TURB, and the re-TURB was negative. So this is only an example of my thinking about this, the use of Bladder EpiCheck in this scenario. So moving to the second scenarios, patient with suspicious of upper tract uterine cancer. Looking at EAU guideline again, urine cytology is the only test accepted during the diagnosis and during the follow-up of patients with a suspicious of upper tract uterine cancer. And we know that we need to collect the urine from the upper tract because the performance of the urine markers is absolutely better in this case. You see the cytology performance is a 74 sensitivity, 66 specificity, just better than to collect collecting the urine from the bladder. The same is for fish. MP22 has the same problem with high sensitivity and very low specificity. So coming back to EpiCheck panel, we know that we have 15 methylation markers in this test. And we know that methylation markers could have a diagnostic prognostic impact in patients with the bladder cancer, with urothelial cancer. So in this review article, they state that DNA methylation is significantly associated with the advanced stage, high rates of tumor progression. Thus, methylation status may be useful as a prognostic marker of bladder cancer. And the methylation markers are more sensitive than cytology in bladder cancer, and only highly selective panel of methylation marker will increase the sensitivity and specificity of urine analysis in the clinic. So my thinking is, can we use this test in these scenarios? The third scenario is patient with asymptomatic patient coming to your office with the urine test showing microhematuria. If you look at the guidelines, the AUA guidelines on evaluation follow-up of asymptomatic microhematuria, they state that all the patient needs cystoscopy and upper tract imaging in this case. No cytology, no urine markers in the guideline, but there is a high risk of imaging using CT scan in this patient, and the cost of this patient are tremendous high. And the AUA guideline conclusion was that we need strategies to avoid full investigation in all these patients. And this might involve investigation of urine-based tests that could have a high enough sensitivity that the negative test might avert unnecessary invasive and radiological evaluation. So this test, you know from the multi-center study, you know from the Professor Shariat's talk, these tests have a high negative predictive value, so probably could be used in these scenarios. So in conclusion, due to its intrinsic characteristics and performance, Bladder EpiCheck is a test potentially applied to different clinical settings. Result of pivotal study EPIC-1 will be expected in 6 months to assess the role in avoiding re-TURB, and other potential application will be investigated soon. And if you are agreed to participate in these new settings, I'm quite satisfied. Thank you very much for your attention.
Okay, Roberto, thank you very much. Nice to have a small view into the future, and I hope it sort of answers your question that we really are looking for other applications of a test like this also in the primary setting. I don't know whether there are any questions. I'll just come up with my last 2 slides, being the conclusion. I think what we heard now is that the test does have a high negative predictive value, even higher if you exclude low-grade T1 tumors. It's easy, robust, and reproducible. I think that's important for a test. There are possibilities to use the test in clinical practice. It will save everybody, patient, urologist, burden and costs. But we have to convince all stakeholders, and I think we just heard very well that that's very important, to talk to your patient, what they expect, what you can give them. And application beyond what we've done today, beyond monitoring, is on the horizon. Check whether you need a re-TRBT, yes or no. We just don't know whether a urologist is going to skip his cystoscopy. I had this question, but Jim already asked that to you, whether you would consider doing a test, a follow-up with the test, and lowering the number of cystoscopies. But I think if there are no more questions, I would like to thank you for your participation and your presence. Unfortunately, you have to go into the cold, but not after some drinks and a dessert, as I have been told. And don't forget to fill in your name if you want to have some tests to test and to get a kit to test your patients at home. Thank you very much.